Good morning, friends. I am Dr. Anupam Agarwal presenting to you our third webinar of second series with Dr. YK Amdekar today. This educational initiative is brought to you by Clinics India through our digital platform DocisLive.com. Friends, GP Clinics is another flagship journal published by Clinics India and is being published every month for last 13 years, as you all know. Friends, the recordings of all the previous webinars of both the series are available on our website gpclinics.in and on our YouTube channel DocisLive.com. Also, the summary of each webinar is published in GP Clinics print edition every month with answers to all the questions asked here. Today's subject is Approach to Skin Rash. Dr. YK Amdekar is the speaker for today's session, as you all know, and he has been the teaching faculty at JJ Group of Hospitals and Institute of Child Health. So over to you, sir.
Well, good morning, friends. I think today's topic is approach to skin rash. And I'm sure that all of us do see the skin rashes so often. And most of the time we are quite foxed about its origin or what's its reason behind it and how to go about it. And I feel we will just learn the clinical approach to this issue so that we can do much better in our practice. Can we have the first slide, please? The first slide, please. Yeah, as usual, we will talk first about the basics. And the first and the most important we all must realize is skin rash is not pathognomonic of any specific disease. So you cannot look at the skin rash or a photograph of a skin rash and give a diagnosis. In fact, several diseases cause similar looking skin rash, and therefore skin rash cannot give you a diagnosis by itself. Well, it can either be a primary skin disease or it may be a part of systemic disorder, and it could also be a benign disorder. It could be sometimes a life-threatening disease, or it could be potentially serious disease. So look, friends, skin disease is not easy to go by. Diagnosis is not possible by looking at it, but it could also be life-threatening or a potentially serious disease. And I think what we look at is really the morphology of skin rash, which helps us to narrow down the probabilities. But it does not tell you what the probable diagnosis or a possible diagnosis is. For example, we know that the rash could be macular, papular, vesicular, pustular, nodular, purpuric. Yes. But looking at that, we can narrow down to some smaller number of probabilities, but still not a diagnostic feature of any particular disease. Besides morphology, we look at the progression of the rash. How does it spread? Where does it start? How does it form any pigmentation or peeling? We look at which are the areas involved. Sometimes it could be all over the body. It could be only central part. It could be only on the palms or soles. Then, is the rash blanching? Is the rash itching? And finally, if there are any other symptoms beside the rash, then what's the time of appearance in relation to all other features? So friends, you will have to look at all this. But the point is, none of the single factor can make us even diagnose the probable cause of skin rash. But we will see over time, while discussing several types of cases, that we can still do our best. Can I have the next slide, please? Now, this is the interaction for you now. Which of the following statements is wrong? This type of skin rash is likely to be dangerous. Purpuric, gangrenous, vesicular, or none of the above? Make a note which is wrong statement out of these four. Your time starts now. Fine. Let's get back to the slide. Now, the house was divided almost equally. What is important is, of course, the type of rash, purpuric and gangrenous, is very dangerous. Purpuric indicates a hemorrhagic rash. Gangrenous indicates that there is likely to be a block in some blood vessels, resulting into a dead tissue. And therefore, some of you thought that vesicular could be a wrong choice. But remember, even vesicular could be going for hemorrhagic rash, and a vesicular rash also could be severe and serious if it involves a large part of the skin as well as a mucous membrane. For example, some of the drugs are known to cause what is known as a Steven-Johnson syndrome, and that can be really dangerous with vesicles not only over the skin but also the mucous membranes in the mouth and so on and so forth. The point is, any one of these rash could be really a dangerous one, and we need to really pick them up and straight away get them to some better type of management. Let's look at the next slide, please. The next slide is also another interaction, and this says itchy skin rash may be seen in viral infection, in malignancy, in vasculitis, or all of the above. Your time starts now. Good. Let's get back to the slide. I think all of you got it absolutely right. Okay. The point is, whenever you have an itchy rash, don't think only of allergy, but it could be varieties of other disorders resulting into itchy rash. So itching doesn't mean only allergy. And to that extent, as we go further discussing cases, we will know how to differentiate one from the other. Let's have a next slide, please. Now, this is a very, very complex and very crowded slide, but I don't want you to really much read everything about it. What I'm trying to say in this is the rashes could be of different kinds that are put in bold here. For example, you have a centrally distributed maculopapular rash, which means it's more in the central part of the body, commonly seen in varieties of disorders. It could be a confluent and blanching erythema, which is typical of scarlet fever or Kawasaki or a toxin induced. It could be vesicular, it could be varicella, many other viruses. But I also talked to you about the Steven-Johnson syndrome and a scalded skin syndrome, again, potentially serious. It could be urticarial rashes. We just learned it could be not only allergy, but viruses, malignancy, vasculitis, drug-induced. It could be purpuric, always dangerous. It could be ITP, leukemia. It could be many other things. It could be nodular rash, which is typical of erythema nodosum or tuberculosis or fungal infection or sometimes rickettsia. It could be red, itchy blisters like some of the viruses, like a Coxsackie, enteroviruses like hand, foot, mouth syndrome. It could be blisters, itchy, typically in scabies. It could be a circular scaly with raised border and a normal skin in between, like a ringworm. It could be silvery scaly rash of psoriasis. It could be a red itchy with very prominent borders. They often ooze, form crusts. It is typical eczema. And finally, it could be white scaly patches largely over the scalp. They easily flake off. They're greasy or oily, and this is seen in seborrhea. I don't want you to remember all this at all, but I want you to know that these are the different types of rashes, but they are not pathognomonic of any particular disease, but they could narrow down your probabilities. And to that extent, they are helpful. And therefore, one of the way to go about is look at the morphology of the rash. Can I have the next slide, please? Now, next clinical approach now is very simple because we have already gone through the basics. But what's the first step anytime you see a skin rash is to rule out a life-threatening disease. And that is important. We have already learned that a purpuric rash, hemorrhagic rash, gangrenous rash. But besides that, any rash where the child or a patient looks extremely sick, often highly febrile, with change in behavior, and many other features like maybe tachypnea, maybe unusual high tachycardia. I think all that should make you think that it could be a dangerous skin rash. Well, skin rash is not dangerous, but the disease is dangerous, and therefore we need to pick up a skin rash that represents a probable danger to life. That's our first step. You may meet occasionally, not often, but don't forget a first day skin rash, which many of you see patients on very first day, could be a beginning of a potentially serious or a dangerous disease, and you must pick that up first. Once you know that it's not immediately dangerous, the next step is to rule out a potentially serious disease. And what is potential serious disease? To begin with, it did not have any hemorrhage, purpura, etc., what we talked, but the fever keeps on increasing, sickness increases, patient becomes irritable, some other features come in along with skin rash. It suggests a potentially serious disease, and therefore you must look at the progression of the disease beside the progression of skin rash and pick up a potentially serious disease. One of the potential serious diseases is meningococcemia. It could be Kawasaki disease, so on and so forth. The point is, you need not worry about which potential serious disease are we looking at, but it's enough to say, oh, this needs to be further investigated, and I can't wait on for a rash to disappear. Having ruled out a serious condition and a potentially serious condition, the next important step, to my mind as a clinician, is to differentiate between is it a rash that is itching or it's the itch that rashes. Take a note of this factor. Many times there is no rash on the skin, but the patient starts feeling itchy and the itch causes a rash. And he doesn't tell you he has been itching. He says, I have a rash and that is itching. We all know that when an patient itches the skin, it rashes, and then he feels more and more itching, and it leads to more and more rashes. But on the other hand, sometimes the origin is a rash, and then it starts itching. These two things come sometimes so close together that the patient may have to think whether the rash came first before the itch or the itch came before the rash. It's very important. Some of the disorders like anxiety, for example, stress, or diabetes, or cholestasis, or even cancer can start with itching on the skin, and it's the itch that gives rise to skin rashes. But the patient is bothered about his skin rash, not about itching, and he does not tell you that the problem started with itching and then developed a rash. I feel it's very important for a clinician to pick up this difference. And once you go through these three steps, the fourth step is really to look at whether I'm dealing with a primary skin disease or a systemic disease coming with skin rash. And that is not difficult because systemic illnesses with skin rash have lot many other symptoms and signs. I hope all this approach is very, very simple and I have made it simplified to an extent possible. And I'm sure this helped me a lot. I'm sure it will help you a lot also. Let's get started with a case discussion now. Can I have the next slide, please? Next slide, please. Yes, this is your first case. A young adult presented with high fever, with severe, intolerable body ache and headache for 2 days. And it was followed by a macular skin rash all over the body. The patient recovered completely over the next 2 3 days. Take a note, high fever with intolerable body ache and headache. 2 days later, a rash, and another 2 days later, entire illness disappeared. Your options are, is it a streptococcal infection? Is it dengue fever? Is it a meningococcal meningitis? Or it could be any of the above. Your time starts now. Can I have the slide back? Now, all of you have got right that it cannot be meningococcal meningitis. The child cannot recover completely. Yes, you're right. So it's not that. What about streptococcal infection? Streptococcal infection can develop the similar way, but there is no complete recovery within 2 3 days. The skin rash may take a longer time because a skin rash of a streptococcal infection lasts a little longer. And even the symptoms like some throat pain which takes time, a dry cough which takes time to recover, and you need an antibiotic, and antibiotic takes another 2 days to get better. So, less likely streptococcal infection, less likely or impossible meningococcal meningitis, and therefore any of the above is not right. This is classically a dengue fever. Make a note, intolerable body ache and headache. Dengue fever is also called by another terminology, and that is a break bone fever. It almost breaks the bones of the patient. The body ache is so severe, it's known as a breaking bone fever. Of course, many such fevers could also have severe headache and body ache, like maybe typhoid or sometimes even other viral infection. But a dengue is very typical of an extremely severe body ache and headache. Okay, and it recovers within no time completely. And I think that's why this rash would be typically a maculoscapular skin rash of a dengue fever. Can I have the next slide, please? The next is a 15-year-old patient who presented with high fever, headache, and maculopapular rash on palms and soles that turned into hemorrhagic rash over the next 2 days. Take a note. Onset with high fever and headache. and the rash, which came almost similarly, but became hemorrhagic in the next 2 days. The diagnosis choice for you is it meningococcal meningitis? Is it rickettsia? Is it immune thrombocytopenic purpura? Or is it acute leukemia? Your time starts now. Let's have a slide back. I've always mentioned in my webinars that I like to also put up something which is a bit complicated, but I thought those of you who come regularly on this platform want to learn more and more. And that's why I put some of those cases which are not so simple. I am aware of it. I've also learned after a long, many years and maybe after many mistakes that I made. But I want to kind of even share those mistakes that I made, must have made. And therefore, let's look at all these options. A typical meningococcal meningitis does not come with a rash only on palms and soles. It's not a maculopapular rash, it's a purpuric rash or a vasculitic rash. And therefore, this rash gradually became hemorrhagic. But to begin with, it was not. So it's not meningococcal meningitis. Could it be immune thrombocytopenic purpura? No. It hardly comes with high fever and headache. In fact, it is related to something that happened few days or a week prior. So you get some simple viral infection, and after a week, an immune response comes up, and that is typically without fever and just a purpuric spots. That is typically an immune thrombocytopenic purpura. Acute leukemia doesn't come with maculopapular rash, again, not only on palms and soles, but it has again a purpuric spots, and that's why it's not acute leukemia. So this is rickettsia. Friends, I wanted to bring rickettsia in the diagnosis of skin rash because it's one of the potentially serious illness. And this can go on to even develop a gangrene. Patients often go into septic shock. And what is important in picking up rickettsia early is the choice of antibiotic is doxycycline. And that is an antibiotic which we commonly don't use in routine bedside practice. And I thought I just wanted to bring such cases also for you so that you remember probability, especially if the patient is getting sicker and sicker day by day, pick him up early, ask for help, and doxycycline may be the right choice of antibiotic. And the control of an infection is pretty quick if you diagnose them early. But if you are late and the patient becomes septic, then possibly he might lose life. Anyway, I, I don't get bothered by not knowing rickettsia, but today we are seeing more and more uncommon infections coming into a clinical practice because we take care of all those common infections by giving antibiotic. But this is one where we need to pick up with a management with a different antibiotic. Can I have the next slide, please? The next case is a 2-year-old who presented with high fever and irritability, followed by a confluent blanching erythematous rash for 4 days. Make a note, high fever and irritability and blanching erythematous rash. On examination, he had glossitis, cheilitis, a purulent conjunctivitis, and also a single lymph node in the leg. See several findings on physical examination. Now, your choice of diagnosis is it scarlet fever? Is it streptococcal toxin induced reaction? Is it Kawasaki disease? Or it could be any of the above. Your time starts now. Get back to the slide. House is quite divided, and I did expect that. Again, to make a point that even skin rash could be of varieties of disorders, which normally we don't deal with them routinely, and many of them get better without our knowledge. That's besides. Scarlet fever could also be typically a confluent blanching erythematous rash, but it does not have a lymph node coming up. Often there could be also a less likely of mouth or a conjunctivitis, etc. It's largely the skin. So it is not. Streptococcal toxin induced reaction could almost look similar, but the typical story coming up within few days after high fever and irritability is unusual. And to that extent, a single lymph node is also unusual. There could be sometimes a small lymph nodes everywhere. And therefore, this is typically a Kawasaki disease. What is Kawasaki disease? It's a type of a vasculitis. And what is important is it has a risk of causing a coronary artery affection. Friends, take a note of this. Some of you who are still younger and are going to practice for next 20, 30 years, you must know this disease very well because this disease is going to be the first common cause of a myocardial infarction in a 30 or 40-year-old adult. I'm sure you all must have heard and seen, even in your practice, sometimes the middle-aged adult develops a myocardial infarction, and it may not be simply a common atherosclerosis or thrombosis, but it could be a vasculitic disorder affecting a coronary artery disease. And today, we have started seeing Kawasaki disease for last 20 years, and we need to be very early in the course of illness and give intravenous immunoglobulins to save this patient from developing a myocardial infarct in middle-aged. Tomorrow's common cause of myocardial infarct in a middle-aged adult is going to be a vasculitis, and one type of vasculitis is Kawasaki disease. Just keep in mind that I wanted you to get sensitized to more complicated problems also of skin rash. And this is just to sensitize us that sometimes the skin rash can lead us to a potentially serious disease. We talked about rickettsia, yes, quite a treatable condition, and even Kawasaki. If you pick up in the first few days, then you can save this person from developing a myocardial infarct in the next 20, 30 years of life. Today, we know after COVID, patients are coming with a myocardial problem or a neurological problem even after 6 months or 12 months after the COVID infection has died out. Viral infections are causing a lot of such long-term problems, and Kawasaki is one of them. And I thought it's a good idea to know them, right? Let's look at the next case. This is a young adult again, presented with high fever for which he received an antibiotic. We don't know what. 2 days later, developed a bullous vesicular rash with peeling of skin, glossitis. Fever continued. Look at all this clearly. Your options are chickenpox, herpes viral infection, drug reaction, or a streptococcal toxin mediated reaction. Your time starts now. Can I have the slide back? Yes, majority of you have said it could be a drug reaction, a small difference. Okay, but your thought process is absolutely right. Okay, many times a drug reaction, if the antibiotic is continued, the fever also is continuing. So here I said fever continued, so you are right. It could be a drug reaction. But don't forget, occasionally streptococcal toxin mediated reaction may look very similar, but there the problem continues even much longer, but without fever also. Whereas here, yes, most of you are right. This is almost like a Steven Johnson syndrome, where many drugs, including some antibiotics, may cause it, and you need to stop the drug at the earliest, and majority of them would get better. But if you do not pick this up as a drug induced and you continue the drug for whatever reason, completion of antibiotic course or whatever, I think you can get into trouble as well. Good. But I think you all picked up so well. Can I have the next slide, please? The next is a young adult who presented with high fever, followed 8 hours later with incoherent speech. Make a note. Within 8 hours of a very high fever, he started talking irrelevantly, and at which time a doctor saw him at 12 hours of presentation and he saw some purpuric spots. Now, your choice is it could be acute leukemia, it could be immune thrombocytopenic purpura, it could be meningococcemia, or it could be any of the above. Your time starts now. Can I have the slide back? I'm so happy. Majority of you got it right. It's a meningococcemia. What is the clue here? Yes, acute leukemia can have also purpuric spots. Then ITP also has, of course, purpuric spot. But what's the small difference? ITP does not come with high fever. We said earlier. It has a preceding fever a week or so prior, and it only comes with a very comfortable child with purpuric spots. He's not even sick looking, and he's not febrile. So it is not ITP. Acute leukemia, yes, but the problem here is this child started talking incoherently. What does it mean? This condition is also affecting the brain. The irrelevant talking indicates an encephalopathy. That means this patient is also, besides having purpura, is developing a symptom related to brain. And that's why it becomes a meningococcemia. And if this child is not immediately treated with penicillin or penicillin light, amoxicillin, but the best is crystalline penicillin, and it quickly within 24-48 hours makes the infection under control. But if we don't pick this up, then he develops a meningococcemia and a septic shock. And then, almost always, the problem may be beyond salvation. So, I think this is important. Look at how incoherent speech indicates an affection of the brain function, irrelevant talking. Any unusual behavior which comes up suddenly indicates that the brain is getting involved. And to that extent, this is a very serious condition. I have seen a child dying within 24 hours of a severe septic shock, which could not be retrieved simply because we thought it could be something that we could investigate, maybe send it to a hematologist. No, this is an infection which can go very fast and kill a person at any age. And therefore, pick up the emergency in a patient who present with a skin rash and high fever. We talked about rickettsia and Kawasaki as a potential serious disorders, and here is one which is immediate danger to life, and that is meningococcemia, completely curable with crystalline penicillin. I think this is one disease where I would even today, in spite of availability of a large number of higher broad spectrum antibiotic, no, you need the most efficient narrow spectrum antibiotic, and that is crystalline penicillin. It kills the meningococcal bacteria very quickly, and the patient recovers excellently. Can I have the next slide, please? The next slide is a young adult who presented with high fever and evanescent rash. What is evanescent rash? A skin rash comes when the fever rises. And when you give paracetamol or whatever antipyretic, the fever comes down and then the rash also disappears. That is called evanescent rash. This is going on for a week. On examination, there was nothing. Your probable diagnosis could be one, viral infection, drug allergic reaction, systemic onset of rheumatoid arthritis, what is today known as a JIA, which is juvenile idiopathic arthritis, or it could be any of the above. Your time starts now. Fine. Let's have the slide back. Most of the conditions like viral infection, okay, or any infection related rash is not evanescent. So this is an evanescent rash. Could it be a drug allergic reaction? Again, till the drug is removed or even after the drug is removed, the rash persists and it's not evanescent. The evanescent rash is a highlight of a systemic onset rheumatoid arthritis. What is systemic onset? Systemic onset of rheumatoid arthritis does not start with joint pains or swelling, but starts only with fever and an evanescent rash. The rash and fever go together. Fever comes down, the rash disappears. And another characteristic of rheumatoid arthritis systemic onset is a fever comes almost every 10-12 hours, not every 4-6 hours like many other infections. Therefore, if you saw a patient with high fever, which comes twice in 24 hours, with an accompanied evanescent rash, it is a systemic onset JIA, and do not give an antibiotic, give an anti-inflammatory, and let the patient know that he may develop arthritis over a week or so, and all that you need to do is to watch the further progress. Sometimes the fever may continue even longer than 2 weeks, And if the fever continues over 4 or 7 days, it's time to seek a second opinion because it could develop any other similar rheumatological disorders. But typical high fever with evanescent rash is a onset of a rheumatoid arthritis where an arthritis may come a week or two later. Until then, you are worried whether it's some serious infection, and therefore, just keep a note. Evanescent rash and a fever coming at 10 12 hours by itself. No, no antipyretic works and keeps the fever down for 10 12 hours. This is a very peculiar syndrome of a systemic onset rheumatoid arthritis. You might see it sometimes, more often seen in younger adults or older children. And typical rheumatoid arthritis coming with joint swelling and pain comes a little later and comes often without fever. Can I have the next slide, please? This is another young adult who presented with itching over the scalp for the last 1 month and itchy skin rash over elbows and knees over the last 2 weeks. The rash was scaly and there was a history of arthritis in the mother of this patient. Take a note of all this. A typical itchy skin rash which was scaly with a history of arthritis in the mother, but no skin rash in the mother and no arthritis in this patient. Your probable diagnosis is seborrhea, contact dermatitis, psoriasis, or any of the above. Your time starts now. Excellent, excellent. Can we get back to the slide? See how you are all so good at some of these things that you have seen. And this is typical psoriasis. What is important of psoriasis? Of course, when you talk about seborrhea, okay, it's often related largely to the scalp, whereas this person is also getting it all over. And there is no relation of arthritis in the mother that I gave. Contact dermatitis are not scaly rashes. They are largely rashes which are reddish, itching locally, and often only at the contact areas, like behind the ears, like in the elbows, and behind the knees. And this is typically psoriasis. I'm so happy that I'm aware that you must have seen psoriasis, but the point to make is in the mother also has a psoriatic arthritis, but she does not have a skin manifestation. And this young adult has a skin manifestation but has not yet developed arthritis. What have we learned with this case? That a type of a disease which is likely to affect multiple systems may choose to present with only one system manifestation. And there could be the history of some other system manifestations of the same disease in the family members. This is one example. If tomorrow this young adult comes to you with long drawn arthritis for a month, and if you ask for the history in the family, and they say, look, there is no family history of arthritis, you must also ask, is there any family history of any other disorders or in particularly skin diseases? And if the answer is yes, oh, this patient of arthritis has another family member who has psoriasis, it could be a psoriatic arthritis. The point I'm making is that sometimes the rash is a manifestation of a general systemic disorder like psoriasis, and it's not a skin disease by itself. And sometimes you pick up this clue by asking a family history in detail. Therefore, friends, as an undergraduate, we learned how to take history, and we said, besides age, sex, etc., we asked for chief complaints, then origin, duration, progress, and then we talked about past history, family history, personal history, travel history, drug history, nutritional history, diet history, so many aspects of history. I'm sure in busy practice, we have lost the track of doing it. And luckily for us, majority of the time we don't even need them. But whenever you don't understand the problem, don't forget to get into a undergraduate mode of history taking and an undergraduate mode of clinical examination, a thorough clinical examination and a thorough history. This is one area I wanted to stress on where a thorough history. And I think you are all experienced clinicians. 95% of the time in our routine practice, we don't need to take all this detailed history. But you need to strongly suspect those 5% of patients where you need to take detailed history. And if you learn to do that, you are able to diagnose diseases which are less common but still are seen in our practice and sometimes even rare but occasionally met with in our practice. And you will get a thrill of having diagnosed them. And I think that's the thrill of practice. Otherwise, our practice becomes routine, same thing daily, again and again, and we get bored. But sometimes you get a thrill of doing something, and that keeps us going strongly. Let's have a next slide, please. This is a 10-year-old who presented with red, rough, itchy skin lesions with clear borders, oozing in a few lesions, and crust formation in some other lesions, scattered all over the body for last 1 month. And your probable diagnosis is atopic dermatitis, contact dermatitis, neurodermatitis, or any of the above. Your time starts now. Can we have the slide back? I think most of you got it right. It's an atopic dermatitis, eczema like. Okay. Contact dermatitis comes only in contact areas largely. What is neurodermatitis? Neurodermatitis is related to anxiety, stress. So, not a skin disease, nor often, and sometimes related to an autonomic nervous system disease. That is the part of neurology. So, neurology takes care of autonomic nervous system as well as possibly the mind, because the mind is a part of neurology. And it's called neurodermatitis. What I mean is, if you have an autonomic nervous system defect, or if you are stressed or you are anxious, you will also get a skin rash. But that skin rash is first itch and then rash. So this is itch rashes and not rash itches. So this is not neurodermatitis. This is not contact dermatitis. So obviously this is not any of the above, but you mostly, majority of you picked it up as atopic dermatitis. Fine. Having given these various different types of cases of skin rash, I'm sure, friends, you must be amazed to see how often we think about skin rash in these varieties of ways. And again, to make a strong plea, I have brought these cases only knowing that those of you who are very regular on this platform are, even at every age and every seniority, want to continue getting educated. And friends, I've completed 82 years. I still am learning medicine. There is no shame, which means I don't know enough. And that's why I brought some difficult problems knowing your capability. Let me see the next slide, please. And this is not important because moment we know it's an infection, we can do some specific tests. If there are other types of autoimmune disorders, rheumatological disorders, yes. If some other organs are likely to be involved, like Kawasaki, you can do an echocardiogram right away. And if it's a primary skin disease, mostly we may have to have a dermatologist to come in and he may do skin biopsy or many other things. In other words, investigations are not an important part of our discussion today. And therefore, can I have the next slide, please? And the next slide takes care of the management. Next slide, please. And again, to take it shortcut on that, if you have scabies, you know you have a permethrin, okay, or your malathion or a benzyl benzoate, our old friend. If it's the ringworm, you have an antifungal agent like clotrimazole, fluconazole, itraconazole, many other. But to me, primary skin diseases are not easy to manage because they go on lurking for a long time. They need a lot of counseling. They need a lot of picking up a best drug possible. And often we start with this approach, but if the patient doesn't get well, it certainly deserves a specialist opinion. Well, if it's an eczema or atopic lesion, we might again like a dermatologist to see, but we must know that, yes, there are emollients, there are moisturizers for dry skin. We use steroids for eczema, atopic, etc. We might like to use anti-itching drugs like antihistaminic, cetirizine, or fexofenadine. We, of course, may have to use antibiotics for infections, and we may have to use anti-inflammatory conditions of NSAIDs or steroids and many other things. This is not very, very important. The next slide, please. The next slide. So take-home message is skin rash is not diagnostic. We saw many overlaps and many things. The characteristics of skin rash may help to narrow down the probabilities. And we decided how to go about it. We have to differentiate between primary skin order and the systemic disorders, which is not difficult. And of course, to begin with, we will rule out serious condition. Details of history often gives a clue. That's important. Early diagnosis of a systemic disorder is a must, and especially if it's going to be a serious disorder. And primary skin disease is best referred to a specialist. I think this is what I would end up with. One more thing that I may add on is a small difference between the cream and an ointment. Many times we are not aware where to prescribe a cream or where to prescribe an ointment. What is the difference? Ointment has 80% of oil and 20% water, whereas the cream has equal amount of oil and water. And therefore, whenever it's a dry skin as a problem, you might like to use a oily substance like ointment. Otherwise, you use a cream. And I think, therefore, always when you prescribe something, you decide whether you add a word cream or an ointment, and that is important. I think back to Dr. Agarwal, I have finished my presentation.
Thank you, sir. So, with your permission, can we take few questions? Hello? Can we take few questions, sir? I think there is some problem with the audio.
I can't
Hello?
hear you somehow.
Yeah. Can we take few questions, sir?
Yes, we can. We can.
Yeah. So the first question is how to suspect dangerous skin rash?
Well, I think, as I said, that dangerous skin rash is a systemic disorder, often comes with high fever, and a very sick looking patient. If you keep these two things in mind, whatever the type of rash, of course, if the rash is purpuric, hemorrhagic, gangrenous, straight off, it is a serious disorder. But even if the rash is not of this type, but the patient has high fever or he looks disproportionately sick, I think time to refer straight on.
Uh,
Any other question?
yes. How to find out an allergen in case of urticaria?
That's a question of great relevance and it's so difficult also. But what do I do as a clinician? Allergens are very difficult to pick up by history alone because patients almost never have observed what is causing a skin reaction. Is it something that you ingest? Is it something that you contacted? But yes, you may get a clue. For example, if I have a rash coming only on my palms, only on my fingers, then I start asking a patient, what did you come in contact with your fingers? But besides that, a skin rash is not easy to pick up. What did you eat? It's impossible. But what I want as a clinician to take a note is that allergy is not only to what you ingest or what you come in contact, but allergy may be due to infecting your organism. Allergy may be due to cancer, to malignancy. And don't forget, if an allergic looking rash is accompanied by a high fever, sick looking person, then this is not simply allergy. He may be itching all over, but he has a systemic disorders behind allergy. And I've seen a Hodgkin's lymphoma coming only with itching and rash. Of course, there it's important to pick up sickness in a patient. So if your allergic patient is sick, I think consider a reference because this is not simple allergy. And I think keep that in mind. The rest of the allergens are impossible to pick up. Leave it to allergy specialists. They could do some tests. I have no much faith on those tests, really. That's my personal opinion. Finally, it's difficult to find out an allergen. Any more questions?
So, a very interesting question is coming. What is the relevance of blanching skin rash?
Come back again.
What is the relevance of blanching skin rash?
Yeah. Now, rashes that have relevance of two things. One, if it's a blanching rash, it means there is an inflammation going on. For example, a purpuric rash is not blanching rash, but a mosquito bite is a blanching rash. Today, in our situation, mosquito bite is a common rash. It's present over the exposed areas of the skin. It may look like purpura, but it is not blanching. So, purpura is blanch. Purpuras don't blanch. Mosquito bites blanch. Blanching is an inflammation. Inflammation may be trauma like a mosquito bite, or it could be allergic inflammation, or it could be infection. So keep a note of that. Non-blanching rash could be the purpura or hemorrhagic rash.
So, I think next question is difference between cream and ointment. You have already answered that, I think. So, and lot many other questions are coming in. I think you may cover all that in GP Clinic's next issue.
Sure.
Right. So, with this, we are ending this program. So, thank you, Dr. Amdekar, for this wonderful session. We hope this interactive session would have made learning interesting for attending doctors to help empower their practice. So, on behalf of Clinics India, DocisLive.com and GP Clinics, I thank all the doctors who have attended this session. Please note the date of our next webinar. It will be 21st January 2024, Sunday 11 a.m., same time. The topic would be clinical approach to mouth ulcers. So thank you once again to all of you. Good day.
Thank you. Good day.